It gives me pleasure to have Dr. Sanjay chairing this session. He's our alumnus. So this is a basic report of what we've been doing on pancreas transplantation for the past 10 years. And this is the context. Everybody knows type 1 diabetes is such a big load in a developing country like ours. And just as an illustration, a child diagnosed with type 1 diabetes at 5 years of age will live another 55 years till the age of 60 in Norway. In a country like Sudan, he'll be dying in the next 6 years. So obviously, we're somewhere in between. And if you look at the prevalence of type 1 diabetes, this chart over here, this table over here, uh, you can see the number of type 1 diabetes, the prevalence suddenly goes down once your age crosses 20 years 20 years. So you can see that India leads if you're the number of type 1 diabetes less aged in 20 years, but then again falls back once you're above 20. So what's happening in that period is patients are dying, and type 1 diabetes, the most common cause of death for them is chronic kidney disease, followed by infections and then ketoacidosis. We know her. She's been there in a lot of slides, and because, like Dr. Sanjay said, we're a close group. We've seen these slides before. She had a difficult time uh, as diabetes with type 1 diabetes with CKD, and underwent a pancreas transplant at PGI, and we nearly lost her immediately afterwards when she developed severe dengue. And it was touch and go at that time. And if you ask us now, all that we can say is we did some supportive management. She pulled through, went on to get a job, get married, and then had a full term pregnancy with no IUGR. The child is now about 2 years of age. Both of them, mother and child, are doing well. So, this is in contrast to what you find is the usual story for type 1 diabetics in India. So, who are we transplanting? I think, again, all of us are familiar with this, some type 2 diabetics, but mostly type 1 diabetics with chronic kidney disease. So, we started in December 2014, actually. If you look at our analysis period over 10 years, so this is 55 patients, 54 of SPK and one of pancreas after kidney. Subsequent to that, the numbers are now 60 and then two, maybe three. So all patients had chronic kidney disease. Two of them are actually pancreas after kidney transplants. And again, two patients with type 2 DM and rest all type 1 DM. So this is of those 62. Male female ratio, and I'd like to draw your attention to the median age at transplantation is 27, mean age at 29, and the mean duration of diabetes 20 years. The mean duration on dialysis is 6 years almost, 72 months. Hemodialysis in all 55 patients, and the dialysis access in all of them was the AV fistula. For donors, the mean age is 25 years, most of them young adult male victims of roadside accidents with a terminal creatinine of 1.1 and terminal serum amylase of 87. Lipase is at a little higher, about 104, 105. Mean kidney ischemia time is 355 minutes, and mean pancreas ischemia time about 520 minutes. We reject recipients who have significant coronary arterial disease, low ejection fraction, advanced vascular disease in the form of calcifications or periarteritis, and frailty is an important aspect for us, and obviously avoiding HLA sensitized recipients. And again, a long list of donors who we have rejected in the past. We are now going on to recently we have taken donors. So the past 5 donors are all who have had history of CPR during the hospital stay, and it's not just the CPR that matters to us, but the course of organ function that we have after the CPR. And again, our youngest donor is 2 years of age, wherein we went ahead and did a en bloc kidney and pancreas transplant into the right iliac fossa. Um, we've had complications, so a fibrosed pancreas, pictures of venous thrombosis, arterial thrombosis, and then on table pancreatitis as it uh, develops. So what we want is good insulin, good function, which is insulin independence from day one and off dialysis again from day one. We would prefer to have blood sugars less than 200, typically in the range, typically less than 150, 160, usually around 100 to 150 is what we would prefer. An hourly output above 200 ml per hour, and serum creatinine halving maybe every 48 to 72 hours, and a mean serum creatinine less than 1.2 milligram percent by post-operative 3, 4. So our complication rates, so relook surgery is about 34% crude rate, and of these collections and pancreatitis washouts being making most of the majority of our relook surgeries. Bleeding in 22%, vascular thrombosis 16%, leaks 10%, and obstruction in 15% of the cases. We have delayed graft function, that is defined as patients requiring dialysis or else significant insulin supplementation afterwards at about 9% crude rate, and our graft pancreatectomy rate was 10%. So one venous thrombosis, two arterial thrombosis, both of them were pancreas after kidney transplants, and two aneurysm bleeds. 30-day mortality is 5% crude rate. So we've divided this is our experience into three. So we had the first year 2014 to 2017, and then 2018 to 20, which is the time when we had to redefine our way of doing pancreas transplantation. And then after that, we've had a relatively stable period for the last 4, maybe 5 years. So we can see we've had some improvement in the mean serum creatinine and significant improvements in the delayed graft function. I think a lot of it correlates to um, the ischemia time that we have had for the pancreas and for the pancreas, and how much the pancreas has had to travel. So re-exploration rate, pancreatectomy rates, insulin independence, and 30-day mortality, all of them show improvement. I think that reflects not just the technical experience, but also what we have learned as to the logistics of going ahead with it. So over the years, what we have changed is the technique, like what works for us locally at PGI. And when I say locally at PGI is when we first started out, we had one of our residents, Sunil, who went to Oxford and came back, and we were we were shadowing that protocol. And what we realized is we were probably anticoagulating our patients much more compared to what we require here at PGI, because our most of our pancreas are in-house retrievals with much shorter ischemia times as compared to a center like Oxford. Um, we always are doing a systemic venous drainage and a jejunum exocrine drainage side to side, and anastomosis. We were doing head up, but I think a couple of recent transplants were head down placements, because now we find that probably head down is easier for us to do. Antibiotic prophylaxis, again, we're finding it difficult right now because a number of our infections, post-operative infections, are now Klebsiella pneumoniae, either multi-drug or else extremely drug resistant. So that's led to the rise of colistin as one of our induction antibiotics. And what we find is colistin does interfere with neuromuscular blockade and recovery post-transplantation. So if you're giving colistin, many of the times we'll find our patients will be on prolonged ventilation after the transplant. The biggest difference, I think, as a junior surgeon, what I've seen is that you have to work quickly but not hurry, so that your ischemia times are short. So our ischemia time, the first transplant took us 14 hours. If I'm right, Dr. Sarpit might be able to recollect better. Now we are down to about 6, 7 hours, and I think that has made the biggest difference for us at PGI Chandigarh. I don't know whether other centers will be able to do this. I think Dr. Jamal's been having problems with this. I think the bigger changes that we've done, which have contributed to our ability to continue the transplant program, have been outside the operation theater also, because type 1 diabetics with CKD in India are actually nobody's patient. Nobody looks after them. And if you want them to come to the operating table, you have to got to take care of them here in India, especially uh, AV fistula and vascular access for dialysis is a big part of our management of type 1 diabetics before transplantation. So we maintain the active listing, and on the listing above, we have about a 30% annual mortality rate, and at any given time, 50% of all our patients will be so-called inactive because they'll be having some complication or the other which requires to be managed. Also, I think we've had a big improvement in the kind of HLA profiling, HLA antibody profiling that we do, and the immunologic risk stratification. So again, extremely important. We feel that to avoid HLA sensitized patients. Uh, Obviously, numbers in the Western world, a number of countries, for example, the USA, UK, Germany, Spain, all showing a decreasing trend in the number of pancreas transplants. I think in a country like India, we're going to have much higher numbers, and we might hope for islet cell transplants, or we might hope for xenotransplants. But for the moment, I think the big need is for uh, whole pancreas transplants, part of SPK or pancreas alone transplants. Thank you.